shall now go on to our next speaker, Dr. Sumita Agarkar, who's going to be talking on pediatric cataract surgeries, the essentials.
Okay, thank you, Dr. Chitra, for giving me this extra 10 seconds and also for inviting me in this webinar. So I'm going to try to summarize the pediatric cataract surgery in 7 minutes. So without move. So how is it different in children? Yes, like etiology, most of it is likely to be intrauterine infection, especially in our country, and also likely to be associated with other ocular and systemic comorbidities, unlike in adults. Of course, needless to say, anatomically, it's more challenging because smaller eyes, tighter anterior chamber depths, shorter axial lengths, each of it brings its own challenge in the anatomical sense. So the questions here are whether are these basically when you look at a child with cataract. So if you look at one by one, how early is early? Well, early surgery increases the risk of glaucoma post-surgery, but this has to be weighed against the risk of deprivational amblyopia. So Birch et al., Lambert et al. Both have recommended surgery by 6 to 8 weeks of age. However, this may have to be modified by child's fitness for anesthesia and systemic conditions, especially in infants. In toddlers, presence of nystagmus or strabismus indicates that cataract is visually significant and needs to be operated. In older children, the decision is based on vision, but size and location of a cataract also may play a role. A posterior located cataract probably is more visually significant than a nuclear cataract. And also to remember that every cataract does not need surgery. And just because we see a cataract, surgery is not to be recommended in every case, because along with cataract or lens, you are also taking away child's accommodation, which is not acceptable, even if however beautifully done IOL you may have placed. So these are examples where probably surgery is neither recommended nor justified ethically. So coming to the pre-op evaluation, comprehensive eye evaluation trumps everything else. Imaging like US ultrasound, UBM, ASOCT, wherever applicable, are valuable in better planning. Surgery should be used as an opportunity. Surgery itself can be used as an opportunity to do a good evaluation under anesthesia. And some of the tests like corneal diameter, axial length, intraocular pressure, baseline keratometry, baseline gonioscopy can all be documented just using 5 minutes before surgery, before the child is draped. And of course, if you are planning an IOL in a very small young child, biometry has to be done under anesthesia. But otherwise, in older children, cooperative children, it can be done otherwise. So coming to the surgery, we are lucky that there is no nucleus and we are all basically aspirationists. So most of the surgery can be done through side ports. Making a side port using MVR blade rather than a side entry knife is better in children because it keeps chamber much better formed. Capsule in children is elastic, and occasional surprises in terms of fibrous capsule you should be ready for. Occasionally, again, most of the lens is very easily possible to do a phaco aspiration or a bimanual aspiration. But occasionally, even in infants, even in very, very young children, you can have a dense calcified nucleus, which requires some amount of technical manipulations in your surgical technique. Needless to say, a cohesive OVD and dyes have made our lives very easy in past 15-20 years. And I cannot imagine doing surgery without either of these in infants. Some of the surprises, nasty surprises, which can be occur on table is a posterior persistent fetal vasculature and posterior capsular dehiscence. This may complicate your postoperative outcomes. So just going step by step on surgery, you can, as I said, capsulotomy is anterior capsulotomy is the key technique here. And you can use both instrumentation, like you can use in a small eye if you feel that you're not going to, like in this case, 9.5 millimeter, if you're not going to use IOL or anything, you can just use your vitrector itself to aspirate and create a capsulotomy, and very easy to, it need not come out at all. While in the other video, as you could see, there is a role for forceps or to do the capsulotomy, which is far more controlled. Now, sometimes you can have, I don't think this video is playing. So sometimes you can have a really fibrous capsule, and here sometimes you may have to change your technique in terms of using scissors to create opening. And good thing to remember here is the capsule, which is not elastic enough to be pulled using a forceps, will not even extend also. So there is a little bit of comfort in that. This capsulotomy is unlikely to extend even despite having a slightly irregular edges compared to a manual capsulotomy, as you can see here. As said earlier, sometimes you can get a nucleus, which is, this is a 1.5-month-old child, and as you can see, there is this solid nucleus. I'm not planning to put an IUL, but finally I had to use something like a chopper using through my other side entry to finally aspirate it without, and it took me 40 minutes to get this phacoaspiration done using, and I did not want to extend the incision, but I was frustrated enough to even consider to actually bring it out through another incision. Now coming to the posterior capsulotomy, again, here the key lies in having retroillumination, where you can see your posterior capsule nicely against red glow. If your microscope affords for a good retroillumination, this step you should switch to retroillumination rather than anything. And as you can see, the force of tearing should always be towards the center, and ideally a good posterior capsulotomy should be 1 millimeter smaller than your anterior capsulotomy, and that gives you a good base and good visual, it prevents visual access of opacification even in very younger children. So sometimes you can have a very, very intumescent cataract, and it is a little bit, here again, the key step is in anterior capsular access, and you may have to actually decompress the lens a bit before doing capsulotomy. Now coming to the correction of aphakia, which you have done following the surgery. Glasses are a very, very viable option in bilateral cataracts, and they do very well. Only thing, important thing is to have a good fitting frame with a big, as you can see here, a clip which allows them to have nasal support. Remember that children do not have nose bone to support your lenses, and something like this should be helpful to keep the fitting better. And a lot of times children reject glasses not because they don't want to wear glasses, but because the fit is poor. Good fitting frames are often expensive, and probably, but it's an investment worth its weight in gold if children can. In unilateral cases, probably contact lenses, both soft lenses and RGP. We have tried both. RGP works better because it provides a better oxygenation and better cover, or better long-term corneal effects are better with RGP.
And you have 1 minute remaining.
But lenses are difficult to fit and have to be customized, and you have to have a good contact with a good contact lens lab to allow you to have this fitting. And last but not least, the IOL, which is now a standard of care for anybody above 1. And I don't think there is anything questionable about putting an intraocular lens in a child who is 1 year and above. However, in infants and young children, it is still complicated. Both IATS study and TAP study suggest that there was no particular visual benefit in contact lenses versus IOLs in infants. However, there was an increase in incidence of visual access specification as well as rates of resurgery. And this probably, but I have both the studies suffered from a slightly flaw in the sense that they were both, the IATS study basically looked at intraocular lenses in children who had unilateral cataract, and my personal take on the study was that probably they did not use enough steroids, which was required, and probably the vitrectomy which they performed using a pars plana route probably was not sufficient. That's why there was so much of VAO incidents in their series. I'm sure there are several authors and several people in this panel who will beg to disagree with the IATS conclusions, and probably again there can be a little bit of cultural differences in when you decide to choose an IOL for infants. So in 2021, this is my personal take on IOL in infants, that it is an anatomical decision, not really dependent on age or laterality. If the eye is of sufficient size, axial length is fairly good, corneal diameter of at least 10.5 millimeter or more, no ocular comorbidities, and a good pupillary dilatation, I would probably implant an IOL. I would also consider socioeconomic factors like ability of parents for follow-up and replacement of contact lenses to help me in deciding. And of course, sometimes availability of other services like having a good glaucoma specialist or instrumentation to check pressures in these children also involves, is something I factor in when I'm taking decision to put or not put IOL. This is the last slide, but most important, we have to talk to the parents, and we must also convince ourselves first that surgery is only the first and the easiest step on a very, very long road. These children need lifelong follow-up in terms of glaucoma, visual axis opacification, retinal detachment, and amblyopia. They need in every visit refraction, intraocular pressure, disc evaluation, and a dilated fundus evaluation. Sometimes if you have access to a wide angle imaging, it is probably a very useful tool in younger children during follow-up. This is my personal opinion on wide angle imaging, but yes, nothing replaces a good comprehensive eye evaluation, which any trained ophthalmologist can do. Thank you for your attention.
That was a very detailed talk and truly very informative. And you answered most of the questions I had for you, but I just thought I'll ask you, what would be the IOL formula today, present day, with the 4th generation formulas all opened up? Which would be the formula you would use for infants and children?
Yeah, so I remember when we started putting IOLs in age 2 and above, maybe 15 years back. At that time also, there was a lot of talk about this and whether you should put IOL, not put IOL. IOL calculations are doubtful. And I'm sorry to note that last year, 2021, in fact, Dr. Savleen Kaur had written an editorial in IGO. I think it was published last month, where the same argument was repeated. In children, there isn't a good IOL formula. So I think truth has remained that there isn't a single good IOL calculation formula which works for younger children. I have no objection for using SRKT, Barrett's for anybody who is above 4 or 5. It works perfectly well. Even SRKT works well. Let's not fool ourselves into thinking only Barrett's and all, nothing doing. But problem with infants and children who are under 2 still remains. Question, you still get DBR surprises of both types, over and under. I think most of it is not problems with the formula, but the problems with how we take the recordings. Yeah. In young children, yeah. Especially if you are doing a lot of these DBRs are under GA, there are issues with centration, and small error in a smaller eye can magnify to a really great extent. What am I using? I use a combination of both SRK2 and Barrett's, and sometimes usually take a mean of both. For children who are younger than 5, older than 5, I use either Barrett's or SRKT. For me, that has worked well, and I think probably everybody can have an access to 2 or more formulas and look at it and come to a thing. But there has been no consensus or no clear advantage of one formula over other in an age group which is younger than 3.
Thank you very much, Doctor.
I have one question.
One question.
No, I think should we take questions? We have so many speakers. I think I went quite wrong by being very relaxed in the beginning, but I want to hear all of them at least for the effort put. So I'm very sorry. We'll keep the questions